Hello everyone, and welcome to Group 10's Quality Improvement Project. Today we present to you our findings with regards to improving patient health and according to the American Diabetes Association, in 2012, 29.1 million Americans suffered from diabetes. Additionally, 1.4 million Americans are diagnosed with diabetes annually. Diabetes can affect many parts of the body and is associated with many serious complications. Some of these life-threatening complications are heart disease, stroke, blindness, kidney failure, and lower limb amputation. Some complications of this disease can be reduced with good glucose control through medication adherence and daily protocols. However, it seems like proper adherence is not always the norm. Each year, non-adherence to medications and patient processes accounts for almost 20% of all hospitalizations and an estimated 125,000 deaths in the United States alone. Lack of adherence to treatment is a common problem with the diabetic population. Many patients drop out of care prematurely. This in turn increases the likelihood of poor clinical outcomes and increases in hospitalization rates. Through our research and health backgrounds, we were able to identify factors that influence a patient's behavior with regards to medication adherence. These factors are driven by social and economic conditions, specific health systems, as well as medical, patient, and therapy conditions. There have been a variety of programs led by health systems, pharmacy benefit managers, or PBMs, and pharmaceutical companies that have been deployed to specifically address the issue of non-adherence in diabetic patients. These programs have demonstrated some good localized success, but as a group, we felt there is still more that could be done. We are recommending a new aim applied and tested across 3 adherence improvement initiatives to reduce diabetes-related complications and costs in aggregate by 15% within 12 months. We will frame a PDSA that outlines what we wish to test, our predictions, the data collection process, specific outcome and process measures, the stakeholders involved, and finally, potential barriers to mitigation. We wanted to take a moment to introduce to you our team members: Nikki, Steven, Kevin, Zora, Wendy, and Megan. As you can see from this slide, we encompass a diverse group ranging from the pharmaceutical industry to the legal industry, hospital services and healthcare industries to graduate students. This group has combined our various talents to research and analyze the topic of non-adherence by really focusing on each individual's specific area of expertise. This has led to some great conversations and debates, as well as collaboration amongst our study, which you will see throughout this presentation. Non-adherence is an umbrella term and can present in patients in a variety of ways. It can range from a patient who stops taking their medication before the course of therapy is complete, to patients taking a dose at the wrong time of day, or perhaps patients not taking their medication at all. According to the Washington Post, an estimated 1/3 to 1/2 of all patients in the U.S. do not take their medications as prescribed by their physicians. As shared already, the diabetes prevalence is very high among Americans, with 29 million diabetic patients in the US alone. Studies show the mean non-adherence rate is upwards of about 37%. As we know, adherence to medications directly affects the clinical outcome of our patients. As you can see from the chart on this slide, adherence is a global issue, with non-adherent patients in the US accounting for $4.2 billion in avoidable costs. These patients increase their likelihood of complications from ESRD, or end-stage renal disease, stroke, myocardial infarction, or MI, and amputation. In addition, a non-compliant patient adds $14.5 thousand to health system costs over the patient's lifetime. Health systems, pharmaceutical companies, and payers have attempted to improve adherence to medicines in diabetes through various programs, but only with localized success. Though we speak about patient counts, the spend on pharmaceuticals is significant and is now over $50 billion per year, not adjusted for manufacturer discounts or rebates. This year alone, that number is expected to grow by 19%. Wendy William was able to share a real-world case study with regards to a diabetic dialysis patient. In one of our hospitals, there is a young diabetic dialysis patient who suffers from ESRD. This patient has frequented our hospital monthly due to poor adherence to both her insulin regimen and non-compliance with regards to going to daily dialysis. When questioned recently as to why she is non-adherent to her insulin regimen, the reply was, "Do you buy food so your children can have a meal, or do you pay your medication copays?" This is common amongst many of our patients who are forced to choose between their family's needs and their medical expenses. With stories like these, our team knew one of the focus points had to be the financial incentives to help offset the high cost of copays these patients are facing annually. As demonstrated by this slide, when we look at healthcare providers such as physicians, pharmacists, along with the legal requirements and regulatory provisions designed to protect patients, we see barriers against medication adherence. However, these same stakeholders also have the potential to facilitate solutions that might help mitigate the negative impact of non-adherence. Patients have the ability to provide emotional support and education with regard to a patient's medication regimen, provided they have the time allotted to spend with their patients during office visits. Pharmacists also have benefit of patient contact. The relationship and connection between a patient and pharmacist can allow them to counsel their patients on the importance of strict medication adherence and the potentially damaging effects of improper usage. Pharmacists must understand and overcome barriers associated with lack of full knowledge of the patient's medical history, as well as privacy issues. However, this barrier may someday be alleviated by having a universal electronic medical record platform system. Legal requirements and regulatory concerns are largely focused on aligning with HIPAA provisions and patient safety. Providers who implement medication adherence programs that result in mailings and other access to personal health information must put in place reasonable privacy measures to ensure that patient privacy rules are not violated. Another area of legal concern is fully understanding the anti-kickback statute and state regulations on Medicaid, along with the rebates allowed for pharmaceutical incentives. Over the years, there have been several programs introduced through the government to help minimize the costs of drugs through rebates offered by Medicaid. However, these programs, when introduced, have to ensure that marketing for the program doesn't run afoul of the anti-kickback statute. Providers are not paying for referrals to certain drug manufacturers, and these same drug manufacturers do not get involved with paying referral fees to the physicians for prescribing its drug. If addressed appropriately, we believe financial incentives can be created to reward those patients who are adherent to their medication regimen. Real-world strategies utilized to improve patient adherence is seen as accountable care organizations, or ACOs. The aim of these ACOs is to improve care management by integrating healthcare professionals across institutions to provide coordinated, high-quality care while reducing overall costs. Value-based reimbursement uses enhanced performance measurements and establishes financial incentives through shared savings programs. Quality metrics like HEDIS, or Healthcare Effectiveness Data and Information Set, and Medicare Star Ratings are used across a variety of metrics to quantify and promote quality of care within the healthcare system. Medicare Medication Therapy Management, or the Medicare MTM program, is seen in the form of a pharmacist or other healthcare professional providing a comprehensive medication review for people with multiple chronic health conditions. This is done to ensure these patients are taking the right treatments and understand the necessity of each prescribed drug. The Enhanced Medicare MTM program establishes financial incentives for payers to identify the underlying reasons for non-adherence, as well as solutions for overcoming these barriers for individual patients. There are a number of real-world case studies that have been applied nationwide to improve patient medication adherence. But we see 3 case studies our team felt really showed positive success with regards to better medication adherence and specifically managing diabetes. The first was the Perform Prescription Drug Therapy Management Program. This offered software alerts to pharmacists about unfilled prescriptions, duplicative or dangerous drug combinations, dosing errors, and other potentially adverse events. Alerts led to actions by healthcare professionals who intervened and applied appropriate patient management protocols. The results showed a decrease in hospital admissions in the study group, as well as lower pharmacy-related costs. The second case study was the Polk County Pharmacists Intervention Model. This utilized on-site clinical pharmacists who conducted counseling sessions with his or her patients around disease-related medications and supplies. This program generated a 30% decrease in hospitalizations and an additional 24% reduction in emergency room visits. The final case study was the Geisinger Health System, which provided a primary care bundled management program to their diabetic patients. Improved clinical outcomes with regards to MI and stroke were seen over a 3-year period in this study group. Not shown here, but other successful adherence programs include those sponsored by Capital District Physicians Health Plan, the Asheville Project, Aetna Prescription Healthy Outcomes, El Rio Community Health Center, and more. Our conclusion as a group is that despite the attention by healthcare stakeholders to improve adherence, reduce medical complications, and lower cost, there is still much more that needs to be done. The issue is only more pressing when one considers the 1.4 million new patients diagnosed annually with diabetes, along with the fact that it is the 7th leading cause of death in the U.S. While we have seen programs show success, if this is not a continued sustained focus in the near future, the death rate and cost factors will continue to increase in this patient population. Even a 1% improvement in adherence results in $2 billion in savings for the U.S. One more time, even a 1% improvement in adherence results in $2 billion in savings to the U.S. The healthcare system will be saving money, and better clinical outcomes for patients will be another result. Our recommendation is tied to IHI's triple aim focus. The priorities are centered on improving the patient experience of care, the health of populations, and reducing the per capita cost of healthcare by reducing the aggregate medical complications and costs in the diabetic population. We suggest developing an integrated approach addressing 3 initiatives simultaneously that is largely and more patient-focused, including providing financial incentives, the use of cell phone apps, and deploying caregivers. This slide represents our suggested PDSA framework view using an integrated approach of financial incentives, cell phone apps, and caregivers. We truly feel these 3 areas could help lead to very positive results in medication adherence amongst this population. Collaboration amongst all disciplines, including physicians, pharmacists, and caregivers, will only help improve the clinical outcomes of these medically diverse patients. Please review our PDSA plan, which includes what we plan to test, our predictions and expectations, and our methods of data collection. In addition, we frame out the measures, including both outcome and process metrics, as well as the stakeholders who need to be involved to ensure the test is successful. Finally, we identify areas needing attention that could be barriers or risks to the project and could require mitigation. I would like to take you through a few elements of our plan. Let's start with what we want to test, ensuring the existence of a test and control group. For the financial incentives, we want to test if offering to rebate back the patient's drug copay will lead to better adherence. For the use of cell phone apps, we want to test how reminders and other messages appearing to the patient's phone will prompt attention to timely prescription consumption. And finally, we plan to test how caregivers working with high-risk patients improve attention to taking medicine. Our predictions for each initiative and data collection methods are further outlined. Finally, as shared, we must ensure our program complies with all federal and state regulations. We hope you enjoyed our presentation. Hopefully now you have a better understanding as to the negative impact medication non-adherence can have, and some innovative ways healthcare industries, patients, and outcomes can be transformed in order to improve the quality of life for patients and reduce overall expenditures. Thank you very much. Have a good day, everyone.